On this episode of the Ask Mike Reinold Show, we talk about some of the strategies we use to restore passive knee extension range of motion after a surgery. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up at Champion PT and Performance up in Boston, Mass, answering all your questions, physical therapy, sports performance, fitness, all that fun stuff, anything you guys want to talk about. I'm here with Mike Scaduto, Dave Tilley, Dan Pope, Lenny Macrina, answering all your questions. Is this like the seating arrangement we're going to go with? I feel like
we have switched a little bit. Sometimes Dan's here.
It feels really good.
Sometimes I'm next to Lenny over there.
That's true. You guys used to be that
As Italian, I like to be by the door in case I need to.
I like to have my back to the wall.
I always want to be facing the door.
Doing it. We're here. We have a lot of students now. We have, throughout the year we get a good variety of students, but there's quite a bit of overlap, which is always good because they get to practice and talk and interact. But 3 students now. Len, would you like to introduce the students to the audience today?
Wow, we do have 3 students.
Yeah.
Well, we'll go seniority, right? We'll go. We'll go 3 students. We'll go Trey Martin, Dr. Trey from East Tennessee State University. We have the longest names right now going on with
I know, right? Yeah.
So Dr. Trey Martin at East Tennessee State University. We have Ryan Johnson from Winston-Salem State University.
Oh my God.
And we have Evan Zervazabik from Trine University. So Trine is somewhere in the middle of Indiana.
Trine?
Trine.
He's from Hogwarts.
Ironically, we have Trey and Ryan and a student from Trine. So Trine and Trine. I don't know.
What a connection.
You guys figured it out. It was meant to be.
I must say, I have never heard of Trine.
No, I haven't either.
Sorry, it's Hogwarts.
Yeah, no, that's good. So it's good, very good. So welcome, Evan. Evan, what's your last name?
Djurdjevic.
Djurdjevic.
That's so fun. Djurdjevic.
That was easy, Len. Why couldn't Len pronounce that? And by the way, I definitely knew his last name prior to asking him. Definitely. So anyway, we have some great questions, right? This is or a question. I think we got one question today. Who do we got this week? Trey, Dr. Trey. Dr. Trey's going to ask the question this week.
So the subject is tips for regaining full knee extension after surgery. So Ellie from Florida asks, what are some methods you find most effective for regaining full knee extension in a post-surgical patient with increased tone in the hamstrings?
You totally distracted me. What's the question? Just read the question part. Wait, what was that? The question part.
All right. What are some methods you find most effective for regaining full knee extension in a post-surgical patient with increased tone in the hamstrings?
All right, so what are the...
just happened?
I don't know. I was like caught on the...
There was a subject there. I thought you wanted it all.
I was trying to...
That's never been there.
I'll answer this question. Jump on it.
Yes. All right, so look, this is a good question. So what are some of the methods that we use to regain full knee extension after surgery? Now Ellie specifically mentioned with tone on the hamstring, which definitely is a thing, right? And is definitely something that happens post-op, but not the only reason why you would have loss of motion. There's a million ways to do this. What do you guys think? Who wants to start? I mean, somebody can ramble on a million things, but like, what do you think is the most important thing to do? A post-op patient comes into you with limited knee extension. Lenny, why don't you start with this and say, what do you look at to determine why maybe they have this loss of motion?
Yeah, I mean, usually it's because they weren't educated at the beginning on how to keep the range of motion. So a big portion of my education, when I first get somebody in, especially after an ACL where there's a lot of pain or a knee replacement, is propping the heel up and allowing that knee to get into extension. The position of comfort is going to be slight flexion, right? Open pack position of the knee is about 20 degrees, so they're going to want to put a pillow under their knee. So education, by all means, first is to get them to understand that getting extension is the most important thing after surgery. You mentioned tone in the hamstrings. Yeah, probably, maybe, because they are going to get shortened over time, but there was a study that came out last year in, I think it was Med Science, Sports and Exercise, that showed that it was the capsule that gets tight and not necessarily the hamstring. So for me, I want to do things that are going to address both hamstring and capsule. So I'm going to look at how you stretch out capsule or collagen tissue. You need prolonged stretch on the knee, so you need prolonged, long duration stretch. So you need the person to prop the leg up and give a good 15 minutes at a time, and we recommend usually 60 minutes total in a day to get the knee to hyperextend, to get into full extension, whether it's beyond zero or not, and symmetrical to the other side. So, you know, get the collagen to stretch out, I think, is the key, and hamstring stretching, maybe some foam rolling, maybe some soft tissue work.
Let me jump in and ask you a question here. So, a couple things. One, I like your approach at first. If somebody comes in tight, the first thing you do is blame them. Love it.
Yes,
that's awesome.
not my
their
fault.
fault.
Blame it on
right?
them.
That is right. Make it very aggressive too. So I like that. No, but I think that was actually an excellent point you made, because everyone's always looking for like the reason. Is this tight? Did that happen? Did this happen? When realistically, sometimes they weren't educated enough, and maybe they spent a week home after surgery and nobody told them to go straight. So I'm jesting, obviously, but I think that was actually a really good point that I like. Tell me about that study though, because remember, in my mind, the hamstrings kind of attach and blend into the capsule to an extent.
Correct.
So how do they differentiate between the hamstrings and the capsule?
So they, unfortunately, they use like rats or some of mice. I think it was mice, and because of their biology is very similar to humans, they basically should put the mice in the cast, their little legs, and for a period of time. I know, we appreciate their contributions to research. And then they looked at the collagen under a microscope to see the changes in the elongation of it. So versus hamstring. So I use this in my courses as well, our online e-seminar course, and anytime I speak. It's the capsule that we primarily have to address, and how do you stretch out collagen is you got to get a prolonged stretch in the knee, if we can even get a substantial change, because it is collagen. But you have a window. A window of opportunity. It's not like the IT band, it's this thick fibrous structure that you need thousands of pounds of force, right? We can get it back, but I think it's more so the tight knee, the tight collagen, the tight capsule. Yeah, that this study showed.
And let's assume for the rest of this conversation, we're talking about like a post-operative knee that is not super chronic.
Right.
Because man, that's a whole nother conversation.
Correct. Yeah,
that's you're talking about somebody 6 months out of an ACL that still has, that's a completely different conversation in my mind. So so I like that. We're in the first like acute, maybe even subacute phase like that. Collagen tissue, prolonged, shorter intensity or less intensity, longer duration type stretching. I like that. So Lenny brought up, I wanted to ask one question, then you jump in, but so Lenny brought up it's collagen and it's the capsule. So talk about prolonged stretching. Does anybody do joint mobs? What do we want to talk about with joint mobs for the knee?
Yeah, I think that, joint mobs are probably not going to be changing the capsular tissue, or like we're not probably moving the capsule around, but it's going to kind of blend into my point. Is like people hurt, man. Like if they're super cranky, the joint is real like angry, and like they've been probably walking on it for a little bit and starting to get sore, and like they're right up there like just in a lot of pain. So like anything you can do a little bit to maybe make them feel comfortable or calm down a little bit. Sometimes joint mobs just make someone relax. Like they're just like completely chilling out. Same thing with like, I think this is again the swing of social media is everyone's like no modalities ever, no passive stuff at all, but like 5 minutes of heat and a little bit of joint mobs would make someone's knee range much easier. Maybe they're just sitting down for 10 minutes, but honestly maybe that's it, but like that can go a huge way to help your manual therapy.
I can't tell how many times people like, oh, I can heat it, I can ice it, and they don't know, and then you maybe heat them because you want just promote heal and relaxation, and maybe it'll blood it to the area, and they're like, wow, that felt amazing. So whether or not social media says it was bad, if that person says I like that, you got to go with it, right?
And if you measure 5 degrees more range of motion by the end of the session, like who cares?
They buy in. You saw the objective change. They feel so much better about their knee. They feel better about their situation. It's a no-brainer, despite the social media world saying there's no evidence or the evidence is negative.
So the funny part is we call that positional release because we have to make like a fancy phrase for everything. They're just sitting there. We'll call it positional
relaxation.
No, but I mean, there's a little bit that we can add a little science to it. So all right, so I think we'd all agree. So with joint mobs, maybe we're neuromodulating tone, maybe we're trying to get them to relax a little bit. But let's say it's 2 weeks out, they're lacking full knee extension, and it's an ACL. Would you do a joint mob?
I still would.
You do a joint mob on the knee 2 weeks out of an ACL reconstruction?
Well, not necessarily an ACL, but I'm thinking like a post-surgical knee, I would still attempt. I think they're still in a period of time where you can have effect. But if I'm trying to not stress the ACL, obviously I wouldn't do that. But
all right, well, definitely patellar mob. That's that I meant more tibiofemoral. Okay, so if it's not ligamentous, we maybe would.
Yeah.
This is good to talk about, so you guys get to hear the discussion here. But like, you know what I mean? So maybe you're right. Patella mob, obviously. Patella's an actually big one too.
It's especially superior to try to get that last little bit if it's extension.
Especially if you have like a patellar tendon graft or maybe even a quad tendon graft to an extent, like patellar mobility is gonna play into this. So we got a whole nother realm right there. So I don't know. So as a group though, ligamentous injury, we're not joint moving, right?
probably not. No.
All right. Thankfully, that's good. Otherwise, we're gonna pause this and
have an internal meeting,
have a champion staff meeting about it. But like maybe other I don't know. I probably wouldn't do it with a meniscus either, to be honest with you.
Be careful with distraction, that type of thing. There's some things you probably still can get away with, but obviously you're not going to translate and try to tear that ACL.
Just do some lock-ins.
Test the graph.
Yeah, I mean it is again probably fine, but again I think the point and reason why I brought up joint mobs is Lenny talked about the collagen tissue, the capsule, and stuff like that. I think theoretically that sustained position, that positional release, that low load, long duration type stretch is probably better than a joint mob on that. And I know there's a lot of manual therapists out there that would go right to joint mobs. I think that's showing us that we may use some joint mobs on the right person at the right time if it's to like neuromodulate, try to get them to relax and move a little bit better. But I think there's other things to do.
I think we've said it on a podcast before, but like you have to have a consistency over intensity mindset. Like Lenny said, like 4 sessions of 10 to 15 minutes a day is better than like one day where you're trying to jam your knee. I made this mistake as a therapist. They come in and it's not straight and you're kind of panicking. You're like, oh God, we gotta get this straight. And you're like really like cranking on someone's knee in one session. It's like, it's probably not the best thing to do, you know, intensity-wise, because that person's gonna leave really kind of sore and they're not gonna want to do their exercises later.
Right, I like it. Good,
and
Mike.
may further promote tone.
Yeah,
like in the muscle, they may get some guarding, especially if we're putting him in a more painful position, trying to gain range of motion. I know Lenny talks about it all the time, like a prone hang. Sometimes will promote more tone in the hamstring because they feel vulnerable there and they want to guard, so they're going to get into more of a flexion contracture. It makes it tougher for them to relax the hamstring. So
I think that's a good point. The question was about what we do, right? And I think I think that's good. Dr. Scaduto is at mikescaduto.com is prone hang, supine, low long duration, and other things like retro walking on the treadmill or retro cone walking or something like that. I'm a supine, like I want them supine, I want them lying down, I want their ankle propped up, and I want a lightweight 5-10 pounds to be pulling their knee into extension and beyond.
The knee, right?
Above the patella, yeah, so not squishing the patella versus the prone hang because of the hamstring getting tight and people just freaking out that their leg is hanging off the table and their pelvis starts twisting out of control, and now the whole thing just becomes chaotic, I feel like, in people that I've tried prone hangs on and the doctor's recommended, so you have to do it, and then it's just, you're like, all right, let's just go back to what I know and trust, and that's just lying down and working on supine.
So we talked about pain, we talked about guarding, we talked about some tone from the surgery and stuff like that. All great. What about swelling?
That's a good point. Yeah.
Right?
Very basic. But
acute-wise, sometimes it's just swelling.
It takes a volume in the knee, causes pain. You want to protect the pain, so
and that's not even the effusion's effect on pain. You're absolutely right. But I mean, we tell everybody there's not a lot of room in the knee, right, for it to go, like for it to like pooch out. And what tends to happen is it tends to pooch out in the back. Right, if you get a big effused knee, obviously it kind of goes all the way around, but in the back there tends to be like a large pooch of that effusion right there, and that's definitely going to be impactful for both flexion and extension of the knee. You kind of see that in both ways. So sometimes it's just getting rid of their pain, getting rid of their swelling, getting them more comfortable so that the way they decrease their guarding, and then getting them into these positional releases like this low load, long durations kind of stretching frequently over time. So if you notice here, we're doing nothing aggressive. We're not doing any manipulations. We're even kind of talking about really not doing that much for joint mobilizations. It's more about getting rid of pain, getting rid of the fusion, getting rid of the guarding, and getting them into these nice sustained positions frequently throughout the day. That's our first attack. If you're talking about a chronic person, a whole other conversation that we won't get into in this podcast. I'm sure we've talked about it. I don't even know. We have like 200 episodes now. I forget what we've talked about, but like that's a whole nother conversation. One other question. What about soft tissue? Nobody said anything about soft tissue. Thoughts?
Gastroc maybe, head to the gastroc or blending in behind the knee as well.
I mean, gastroc, hammy, both cross the knee. right? So theoretically, if you're in a shortened position, those guys get toned up. They start to, yeah, you know, I mean, is that a part of it too? So we would all do that, right? All right, so let's summarize. Let's say you come in, you're 3 weeks out of ACL reconstruction, and you're lacking a little bit of knee extension. What are we gonna do? First thing we can probably do is hop them up on the table supine, right? We're gonna probably put a hot pack on their knee and put their heel propped up and let it just slowly sit there 5-10 minutes, see what we get for range of motion. From there, I think we're all going to probably go soft tissue, right? We're probably going to go hamstring, gastroc, but then also a fusion-based soft tissue if there's anything going on with the knee, right? From there, we're probably going to go patellar mobilizations, right? Going to do some patellar mobs, and then from there, we're probably going to then try to actively get them engage their knee so that way it goes straight. So knee extensions, retro cone walking, like Lenny said, even just walking, yeah, you're just a quad set, right? Like that's a great point, just a quad set. We're going to actively get them in that position, and then we're probably going to ice, and then we're probably going to compress it with a wrap or a sleeve afterwards, right? Pretty comprehensive?
Nailed it.
There you go. So summary in the last minute, but I like how we kind of brought that all together. Does that make sense? I think everybody wants to jump right into like, oh, this is a problem, I got to be aggressive and do something, where it's actually pretty simple and you take a step back. Awesome. So good. I like it when we can answer a question like that and we can kind of almost have like a little case at the end. So hopefully maybe you can watch that again, watch that last minute or two again, maybe put it down to 0.75 times speed on the audio there. I kind of talked like Dave on that one. I apologize. But good question. Hopefully that was a good understanding of our treatment approach of what we would do with that person. So if you have a question like that, head to MikeReinold.com, click on that podcast link, and be sure to fill out the form to ask us anything. Really, we get so many diverse questions. We love hearing them. So keep sending them. We'll keep answering them, and we'll see you on the next episode.